Welcome to our BMJ Quality webinar. We're very happy to have with us today Professor Terry Young from Brunel University. Terry is going to be talking to us about why we should model in healthcare, challenges in healthcare that modelling is appropriate for is that healthcare needs to reconfigure rapidly, and modelling methods can be used to prove and test new systems at low cost and risk. Increasingly, service providers recognise the problems with the system, and modelling is very amenable to highly complex situations. We need to model because strong metrics are key to a system of centrally managed outcomes but locally managed provision, such as we have in healthcare, and many healthcare organisations model to understand how to set these appropriate metrics. Terry Young is going to explain further.
Are responsible for how it's delivered, but you want centrally to be able to manage a common delivery across lots of locales. You have to find some way of setting up metrics. And those can be quite difficult to set up, and one of the advantages of modeling is that you should be able to play with various configurations and work out what sort of metrics work. And then finally, as we try and move away from reaction towards a more planned and in particular a more risk-managed approach, I think that the simulation and modeling has the ability to make forward predictions and help us to stop saying, what should we do next, to asking the first question, where did we expect to be by this stage, and how do we exception manage where we're at? So those are some of the challenges that I think there's a lot more consensus building around those, and in each case, people in other sectors are using modeling very significantly. Real-time modeling has been used in lots of other sectors. One thinks about the aircraft industry, civil or military, where they're always making predictions, when am I going to reach my destination? And increasingly, we find those in our everyday lives in terms of, for instance, the automotive environment, how far until I need to fill up with fuel, how long until I get to my destination. And increasingly, those models are becoming more sophisticated. So they're able to account, for instance, for traffic levels, for road closures, for lots of real-time things. They're not perfect yet, but they do help us significantly, and we become more and more reliant upon them. We make decisions based upon the fact that we're setting out on a 50-mile journey and we've got 30 miles of fuel in the tank according to our little model. Not a perfect model, but it's enough for us to make decisions with. There are some worlds where people in those worlds would find it difficult to distinguish between the model and the reality. So if you were a chemical plant engineer, you would probably think very much in terms of the model whenever you were asked a question about what you were going to do next. So a large order for I don't know, several hundreds of kilograms of paint comes in maybe. And one of the things you might do is run it through the model, first of all, to see whether you can schedule it, whether you've got the capacity, whether the system will work that way. And so there are parts of our world where people are already very heavily dependent upon the model for redesigning, for setting up their metrics, and in particular for real-time decision-making. One of the things that impressed me most, I lecture project management to the final years, and when I first watched the Apollo 13 film, Ron Howard's portrayal of the Apollo 13 saga, Ed Harris plays a guy who's in charge, the flight director, somebody called Gene Kranz. And one of the things, if you watch the film, you'll remember the man in the white waistcoat whose wife gives him a new waistcoat every time he does a moon mission. And I was impressed with him as a project manager. I liked the way that he separated real-time problems from strategic problems. He creates two teams, one to keep the astronauts alive, one to find out how you're going to get them home again. He has a way of delegating power to people. There's a scene in the film where they need to create a carbon dioxide filter, and he works out what's in the cabin there. He piles it up on a table. He brings his experts in. He says, I can't do this. You need to solve this problem, and I need an answer in. And he gives them how long it is that they have to work out a solution and then beam it up to the astronauts. So I really liked the way he was doing it, and I thought I really need to get my students to watch this film, and this year, in fact, we're going to sit them all down and we'll watch the film together and talk about project management afterwards, I hope. But two things that came out of the moon missions were, first of all, the creation of a decision-making network around the world that worked in real time, even though the infrastructure was very, very primitive. But the second thing was the way in which they used modeling. So they would they would have a team that was running a mission, and then they would have a team that would try and set up a series of scenarios that would lead them to a position that might lead to failure. And every time they reached a failure point, they all got together and worked out what the next bit of the protocol was. And there was a huge amount of gaming that went on where one team was running the missions and another team was trying to work out scenarios that might catch them out. And as a result of that, they delivered something that was unprecedented at the time, and they brought back a lot of people alive who might not have survived. And this role of modeling has really sort of stuck with me as I've been thinking about this problem. There are a number of barriers in healthcare to simulation and modeling. One is that the healthcare environment is often much happier with a hands-on improvement approach, something that you work through maybe over a period of weeks or even months. I don't think the whole area of evidence is highly contested. There isn't anything like the clarity around the evidence of logistics and process improvement that there is in evidence-based medicine and clinical decision-making. Culturally, there's a strong focus on the patient in front of you, and there's less awareness for many clinicians on the system around them, and we certainly don't know how to scale up best practice from pilots. So the ways to get over those barriers are we do have to build some capacity of people in the UK who are familiar with systems thinking. And just before Christmas, I discovered that US hospitals were recruiting industrial engineers, not in their hundreds of thousands, but certainly I heard of one hospital group that had taken on about 30 industrial engineers to help sort out its processes. We need to develop methods around evidence and build libraries of evidence for the logistics side, the care delivery side of health. And in terms of the culture, we need to make sure that medics and others are able to see redesign and the benefits firsthand, that they have some experience to react from. And I think ultimately we're going to have to run some sort of trial at scale. It won't be a randomized control trial. You won't be able to do double blinding and stuff, but we have to do something that works at scale and allows us to begin to emulate something of the excellence of evidence-based medicine. The military has a system that works from sort of physical models at base level all the way up to geopolitical models. So you might have a model of a platform, a ship's hull or something like that, and you'll also have models at the top level of what happens as water runs out in the Jordan River, for instance, or some political hotspot. And in between, there are a series of models about how the platform will respond, how it will undertake a mission. There'll be scenarios about different types of units working together. And they don't quite connect up, but the intent is to have them as integrated as possible. Probably if we spent something like the military in terms of healthcare modeling, we'd have a very sizable health knowledge economy around simulation and modeling. There are some physical models. You can get blood flow models. There are people that have looked at how you design implants and stuff like that. There are some models of facilities. There are some workflow models. And there are some policy models, probably more policy modeling done than anything else. A project that several of us worked on, now I suppose it finished in 2009, was to create a toolkit that would help people to understand what modeling they might choose to adopt given a set of problems. So how much money did they have, what sort of a problem, how much data, how much they know about their problem, and so forth. And that's still up and running on that particular website. I'm sorry, it's not a very easily accessible website, but you can find that toolkit on that, and it will give you some feedback. So that's where I think we're aspiring to go in terms of embedding simulation and modeling in the healthcare environment. I thought I'd pause for a couple of minutes and maybe pick up some questions, Kat.
Thank you very much, Terry. Fascinating so far. I have a question for you. A lot of and I'm sure you're going to go on and answer this later on in the talk, but a lot of the barriers you talked about are cultural barriers, saying that we in healthcare like to rely on our experience and expertise. We prefer hands-on improvement. We're good at focusing on the patient, not the system. You've given us some answers about how we can build a knowledge economy and an evidence base, but how do you think we can approach some of those cultural factors more?
Dennis Cortese, who used to run the Mayo, came over and did a talk earlier on in the year, and he gave 2 rules of thumb. One was the rule of 8, which says if you want to change anybody's mind, you have to tell them 8 times, and I think sometimes that's interpreted as 8 times in 8 different ways. And I think that there is the message does have to be reinforced. But a really interesting message, a really interesting rule that he used was the rule of root N. So if you've got an organization that has N people in it, you probably need to influence root N of them so that they're really behind this. And the NHS has about 1 million people. So we need to find maybe 1,000 people whose minds we can change in a very fundamental way, probably through doing things that they engage in and work out how to make this work for themselves. I don't think it can be imposed on the culture. There's got to be a way for the culture to say, let's try it. How do we want to use it? How do we make it work for us?
Mm-hmm. And you gave some really interesting examples of some models that have been created in healthcare, in the policy models, physical models. And as you said, organisations have to embrace these from the ground up. Are there any organisations who are using these models in practice that you can tell us about, or is that coming later?
Well, I'm gonna work through one example. I think in the States where there's a clear link between the cost of care delivery and the viability of the care delivery organization, there are a number of consultancies that make a living out of going into hospitals and modeling them and finding savings and stuff like that. I think a lot of the really big savings, though, are probably not in shaving 5 or 10% off any given facility or clinic or whatever, but they're about reconfiguring the system so that you are running it much more in a completely different way. If you look at what happened in retail, for instance, in the last sort of last quarter of the last century, places moved from supermarkets, for instance, moved from having their own sort of local warehouse right next to or within the supermarket to completely lean delivery, where supermarkets now don't have what isn't on the shelves by and large, and it's all delivered on a daily basis by a logistics force that makes sure that you get exactly what you need when you need it. Now, that's a profound change, and it's not just about making the supermarket that little bit more efficient or whatever. It's about changing the whole way in which the system is configured, and I suspect that that's where the real system, the real benefits are. And I'm not sure that we've done that in health yet. In the States, they don't have cradle to grave, so bits of the system they can improve. It's places like the UK where you have a very integrated aspiration around healthcare, where I think the unusual benefits could be achieved early. Does that answer the question?
Absolutely, and I think it's the holy grail of quality in healthcare at the moment is how can we redesign the system on a large scale, and I think absolutely the fear is the lack of evidence, and how do we know how can we make large scale change because there are so many risks inherent. And I think, as you said, if we have good evidence from modelling that this will be beneficial change, that would be a very powerful opportunity. We've got a question from one of our participants, John. And he asks, in the NHS, who really owns the responsibility for optimising processes and pathways, would you say?
I think that's another really good question, and that may be something that we should have put in the cultural side, in the sense that I'm not sure that there is one point at which it happens. I think ultimately, I think the NHS is probably an organization where the processes are defined by the training program that the people who are in it went through. So I suppose that the uniting comes from an educational background and how people are trained. I think it's a really complex problem, because ownership is not just about who's responsible for the operational costs or whatever. It's also a question who's willing to buy in to the way in which change takes place. And that may be another reason why it's extremely difficult to get into, but it's also another reason why modeling is so powerful, because it allows these communities to gather around a common representation of a problem and to discuss it together.
Mm-hmm. Fantastic. I hope that answers your question. Shall we move on to the next section, Terry?
Sure. Let's go. So I wanted to give an example of a piece of modeling. This is a piece of modeling that was done using discrete event simulation, and it's quite complex, the picture that I'm going to put in front of you, and I just wanted to acknowledge Julie Etok's work there on this particular problem. Here we have a representation. This is a fairly high-level view of the model that she put together. So the reception that you're coming in from the right-hand side, you've got reception, you've got your minors, you've got your majors, you've got your pediatrics, and you've got your resuscitation. And in structural terms, an awful lot of A&E departments are like that. It's the local hospital right next door to us that was modeled here, and this model is a few years old now. You'll see that there's a lot of structure in there, and so the sorts of things that one of those will open up and reveal are a series of facilities and places that patients go. So they go from triage to assessment. They may start to receive some treatment, or they may go for a diagnosis and then go on to treatment. And there are pathways that are defined in the model, and there are statistical algorithms that look after the way in which patients go through that system. And if this is just a single slide, if this were a live model running, you would see those queues getting bigger and smaller throughout the day as the model ran through the day. One of the tricky bits, and something I want to come back to a little bit later, is that running this kind of care provision represents the clash, really, of two cultures. One is a medical culture that people should be treated in terms of the medical priority, and the other is some sort of processing culture where you have to get people through because they've turned up, whether they're a priority or not. And one of the ways that the health system dealt with this was when there was a deadline to be met in terms of getting patients through. As you came up to that deadline, 4 hours when we were dealing with this, when you came up to the 4-hour deadline, they would sort of change from choosing people according to medical priority to choosing people in order to get them out so that there wasn't a breach. And the way in which this model handles that is you'll see people have got different colors. So most people are green, which means they've still got a long wait before they become a process priority, although they're going to be treated on a medical priority basis up until then. You'll see that there are some people that are red, which means they're coming up to the time when they really ought to be getting through and out of the system. And I think on this one, there's one blue person up on the left-hand side. And blue people are breaches. And the model didn't handle breaches as accurately as it handled everything else. But what you can see here is that superimposed on this sort of medical model was a time model to try and identify how long people had been in there. And then in this model, it simply pulled them out of the queue and put them to the front of the next queue to get them through as quickly as possible. And it was quite difficult to work out exactly what was happening. So you can build the sort of the structure of what you understand is happening. What people tell you in the system is how patients go through. A lot of times there are sort of unofficial ways in which people actually do things. So you've got perhaps a formal view of what's happening, and then there's often informal things happening. And in this particular case, there are things that are really hard to model. So the consultant told us every now and again that he would wander around and he would pick up cards of patients and he would reprioritize them right there, and according to what he felt the priority for them was. And that's obviously very difficult to model that kind of very ad hoc process as people are going through. But you can set your model up and then take some data, some input data. This was some real data averaged over a couple of weeks. You can see that it varies from time to time of the day. And then this is a picture of the results. So you're looking you've worked out how long every patient takes to go through. This has been averaged over many thousands of runs, and so I suppose this is for Aston Villa fans, really, isn't it? The claret is the actual data that was averaged over a couple of weeks, and then the blue is the model data, and that's pretty good agreement over the 4 hours. And you'll see that as you come up to 4 hours, there's this sort of massive increase in patients leaving the A&E. As I said, breaches weren't as well handled as perhaps the rest of the system because Julie felt that once people had breached, she just sort of left them. And obviously, if that was really important, you would come back and perhaps improve that bit of the model a little bit. But the agreement there is really exceptional. And I think this was the first model that really went to look at the sort of the ski slope or the blip at 4 hours and really tried to model that out. And it took us a long time to work out what processes were really taking place around that period. That's one set of results. Because of the time, I just wanted to give people an idea of what could be done with a model like this. There were two things that were actually studied. One was the use of an emergency nurse practitioner who was to pick up certain patients and sort of track them around the side of the system. And in fact, during the time that we were building this model, they had time to experiment with that, and we were able to show that that didn't make a big difference, particularly to the 4-hour problem. And indeed, that's what they experienced when they did it. The one thing that we found that did make a difference in terms of throughput was to put majors and minors together and to use the same cohort of staff to do that. But that didn't turn into an experiment that was run separately. So that's the sort of thing that you can begin to look at. You can look at rostering changes. You can look at protocol changes. You can look at the way in which you wire up the system, and you can explore those kinds of things. We had a number of different communities. So clinicians get worried as they come up to the 4 hours, and they tend to change their priority as they get towards the 4 hours. So there's quite a lot of interest around the 4-hour glitch there. We showed it, excuse me, to one manager, and that manager just fixated really on the fact that all these breaches were going to cost a lot of money. It was a chief executive, looked at this slide and said, "Wow, these breaches are going to cost all kinds of money if this were in my in my facility." And so that's a different sort of reaction to the slide. And of course, if you showed it to a process engineer, what they would say is actually you would treat people better if you could treat them almost more like nuts and bolts and just focus on moving the peak of that distribution earlier. So you try and get most of the people through very much quicker, whatever their clinical priority or their medical condition. If you could just find ways of moving them through quicker, then by the time you got to 4 hours, you would be exception managing very small numbers of patients at that stage. And so that's an example of putting a model together. It's quite a complex model. You can do a lot that's very much simpler than that and can be done much more quickly. And then you can start to bring different communities together and start to ask questions that are very different and have discussions based upon a perception that becomes much more common about what the issues are. And I think once again, it's quite brief, but I just thought I'd take a break there and find out whether there are any questions coming up from there.
Thank you very much. I think the concept of bringing people together to have a conversation about, like you said, a common understanding of what takes place rather than an understanding coloured by their particular professional viewpoint is a very useful thing, because that can often be a real barrier to understanding your processes. It doesn't look like anyone has any particular questions at this time. Is there anything else you wanted to add about that section?
No, I'm quite happy to press ahead and pick up more questions at the end if that will work out.
Let's do that.
Okay. So where next? Where is it that we'd like to go? How is it that we'd like to see some of these sorts of tools and many others that are similar? How would we like to see those deployed? And I guess ultimately we would like to see all kinds of care delivery environments working their way around some kind of an evidence-driven improvement cycle. So if you conceptualize the care that you deliver in terms of, I don't know, somewhere between 20 and 40 service lines. A service line might be your clinical lab facility. It could be something, depending on how you define it, that you think of more in terms of pathways, maybe your cardio services. It could be something like radiology. However you go about deciding what it is that defines the entity that allows you to deliver care, there'll probably be somewhere between 20 of those services and 40 that you would be able to define. And some of those may be patient-facing and some of them may be internally facing. So some of them may be to support clinicians and some of them may be to support patients. What we'd like people to be able to do is to pick up at the top there in the green box and to get some really good cost-effectiveness analysis of their different service lines. So it's not just that you want to be able to compare your outcomes with other people's outcomes. You want to be able to compare the outcomes and the cost of delivering those outcomes with other people's outcomes and the cost that they're paying to deliver the outcomes that they're delivering. And there's not a lot of that around. Obviously, people like Dr. Foster and others are pioneering a way of using data to begin to get some internal measures, but I think it's still very early days at the moment. Given that, you can begin to say, well, actually, we're going to pick this up. So I don't know, maybe you're going to pick up your renal services and be looking at sort of dialysis options and stuff like that. So you pick up one area, and then you want to be able to dive down into the data, and you want to be able to get a lot of rich data about what's happening, about how you're configuring it, about what other people are able to do, and get lots and lots of information out. And then coming round to the light blue box, you want to be able to model different ways of doing that. So you might do it using the sort of model that I've looked at. In the Cumberland Initiative, we're not trying to push a particular modeling method. There are lots of different ways in which you might model something like that. And you might set up experiments and sort of game it out yourself. You might be like the Apollo space mission people and actually have teams that sort of run games to try and work out the best way of doing it. You might run a game of commissioners with providers or whatever, but somehow you want to do some modeling, to have some numbers, to work out how you're going to reconfigure the service that you're working on. That's not going to work on its own. Once you know the choreography of care, once you've got your footfall worked out, you've then got to embed that in your information system. So you want your EPR to be able both to furnish the data that the model will need, but also to take in data and to furnish the management information that will be needed to ensure that you can drive things through in the way that you've decided to do. And then there's a big cultural change piece, implementation. You'd have to work with a specialist group probably in order to do that. You come up to the top again and you ask yourself the question, have we improved this? And hopefully the answer will be yes, and there will be higher quality, and there will also be greater efficiency and lower costs coming out of that. And then you would probably pick up one or two new ones and then work your way around. Data and evidence, there's lots of data around, but there's almost too much of it. Very little of it is sort of cleansed or available for people to use in terms of these kind of inquiries. Models, there's modeling's been going on in healthcare environments for decades. A lot of it's been very, very specific to the academic who's done the modeling and the clinician or the clinical group that's been associated with, that they're associated with in some way. What you really want is models that are at some level generic. So it would be nice to have maybe 3 or 4 models of the best A&E layouts and some information, some model data that you could feed into that, and then you could begin to substitute that sort of generic data with data about your own patient throughput statistics, your own rostering practices, and so forth. In terms of information architectures and applications, again, there's people often tend to be hooked into one particular supplier. What we want to know is what sort of apps and other software can we put around that in order to accommodate the change in practice that you're contemplating. So in a lot of this area, it's really quite limited. Now, the Cumberland Initiative is really interested in the blue box and the adjacent boxes. A bit of big data, we're certainly interested in how you get the data, how you cleanse the data, how you triangulate between data sources, how you make that available, possibly processing very crude data to get more sophisticated data that can feed into models. And then we're also interested in how those models will be embedded or interface with the information architectures that are out there. And we'll clearly need to work with other partners. But the sort of the sector of this diagram that we're really interested in is around the blue box. I suppose I'm an extremist. I like the idea of model-driven healthcare. I like the idea that we might get to a stage one day where the model describes both the care in terms of the concept, and from that you can get your process maps and everything else, but is also used is also running live and is used to work out whether you're meeting your metrics, is used to help interpret your performance when you're not meeting your metrics, when that model is used in real time to deliver warnings. So one of the slides I didn't include when I was going through the A&E example was we put together, Julie put a little slide together that showed the probability of breach 4 hours later at the same time as each new person entered. And it wasn't a predictive model because it had all been run historically, but she was able to draw that historical information out and to say, actually, if you produced a predictive model, you could say each time a new patient presented what the prediction was 4 hours out in terms of the capacity. And that kind of predictive stuff is very, very powerful, not just in terms of working out what strategies you might take, but also in terms of signaling ahead that these people are going to be leaving this facility. You know, these people are going to be leaving on our ward of 20 people. Maybe we know that 3 of them are going to leave within the next 8 hours. And what provision is being made, what sort of services are being dialed up for those people, what are the transport arrangements, what are the other arrangements of social care or whatever. So using your models to signal ahead and to make stuff available, and that's why the model has to connect into the information architecture. Your model in your car that tells you how far you can drive until you run out of fuel is only worth something because it's connected into your engine management system and it's tracking the rate at which you're using fuel and other things. And then you want those embedded models to be driving your measurement systems so that when you come to make these comparative analyses between what is, the outcomes that you're achieving and how much it's costing you to achieve those outcomes, you've got much better data to do that. So that's the sort of the world that we would like to help to create in healthcare, where people can work around that kind of cycle. We've been given a building. I expect the thing will be signed off in the next day or so. It's with the lawyers. SEGRO, and again, you can click on the link there for a virtual tour of the building. SEGRO have offered us rent-free a building for 3 years to see whether something like this can really work. Can we, first of all, can we solve some of the healthcare problems, but also can we start to deliver the economic impact by drawing in companies and creating a knowledge economy around healthcare? And they've been really good to us. That's an example of one of the rooms in the building. But what's really attractive about this building is that there's a huge warehouse out the back. And it's that warehouse that I'd like to see us using for gaming, for modeling, putting models up on the walls, getting communities of people together to solve significant process problems at a scale that's meaningful for related to the problem. This diagram is one way in which we might use a building like that to try and track problems. So working from the left, what we want is for major delivery problems to be identified. And each of the dark blue shapes has got a little button system. So green is clinicians and clinical managers, and purple is academic health science networks. And we're looking for for major delivery problems to be put forward by those communities. And I suppose we're taking an industrial view of processes here. So we're assuming that in processes that are hitting problems, first of all, there's quality that can be engineered in. And by that, I mean that each time somebody presents, they can expect the same level of service, the same timeliness, the same responsiveness, the same thing to happen to them. And the better you can do that, the higher the quality of your process delivery. So you're assuming that you can find ways to engineer that in so that it becomes a natural part of the process. And secondly, you're assuming that there is waste to be engineered out. So waste takes many forms. It takes the form of delay. It takes the form of having to do the same thing over and over again. It takes the form of people bouncing around a system and representing, sometimes haphazardly, at the same place. It takes the form of people having to give the same sort of information or re-enter the same sort of information over and over again. There's lots of ways in which waste presents itself, and anybody who engages for any period of time with a real health delivery environment will experience all kinds of waste. Then what we want to do is to get industry and academics to say, well, if this were an industrial problem, we would tackle it this way. So you want a list of options or ways of thinking about the problem to be put forward, and then for those to be shortlisted by the clinical and clinical managing community. So you're probably going to have a bit of a looping around going there, and people say, actually, we just can't do that. That is just an industrial far. Or people would say, actually, there's something quite exciting here, but we don't think that works really in our environment. Can we change this a little bit? How could we make it a bit more human-friendly or patient-friendly or whatever? And then you want to game it out. Once you've got a short list of maybe one or two options, by playing a game in a warehouse, by getting a group of people together and running some models against each other. And I just want to draw attention to the orange button there, because I think that there are ways in which patients might be able to engage with this kind of world, a modeling world, that they can't engage with other sorts of experiments. So you might put some of this stuff up on a web page, and people might say, actually, here's my reaction to this way of doing it. Or you might create some models that are actually not taking place in a building at all, but are actually out there on the web the whole time, and you're asking people who have had a particular care delivery experience to reconfigure the world. And maybe there's a little Lego model type thing where they turn the blocks around and say, actually, I'd like it to be this way. And they press a button and it does some analysis. And it says, actually, this would take 4 hours less. Or it might say that, this gives a better experience, but it's going to cost an extra £1,000 a pop or whatever. So I think that there are ways in which we might find to engage with patients that we're not able to do at the moment. Out of that will come solutions, and that's obviously the really valuable piece to people. And then I think that we've got to find a way to move from understanding that we have a solution to working out exactly how that gets embedded in a real care delivery environment. And then what we need to be able to do is to put all of that into some kind of library or repository. And I'm hoping that as we go through with the Cumberland Initiative, we'll build up a set of models that people can come to, and that both in terms of pitching up physically at the warehouse, but also in terms of looking at the repositories, people will be able to work out what their top 2 or 3 options might be when they're looking for change. So that's a sort of a method that we're looking at. Where are we at the moment? Well, we have a vision to see a much more systemic and systematic use of simulation, modeling, risk prediction, those kinds of sort of industrial type tools applied to healthcare. And we accept that there's a huge gap to be bridged in terms of the domains from which some of these tools came and the domain into which we're seeking to see them applied. There's a building, there's a bit of a brand, there's some capability. Probably of 80–90% of the people that have been involved in healthcare simulation modeling are associated with the Cumberland. So we've worked with a community over a number of years to bring that together, and there is some expertise. And I'll fill that in a little bit more detail in a second. Where we'd like to be is to have a dream environment for three communities. We'd like academics to want to come to the Cumberland Initiative either in the building or perhaps as part of the network, because it represents a dream sabbatical destination. It's a place where really exciting things are happening, where the most complex problems are being presented, where the most ingenious solutions are being developed, and where some of the brightest people are gravitating to. We want industry to come along because it's the place where the clinicians are working out how they really want to deliver stuff. And I think one of the big problems at the moment is there is a disconnect between industry, which I think has a huge capacity for a huge potential for improvement in healthcare, and the clinical people that are designing new processes and stuff. And hopefully an environment like this where people are coming, a neutral space where people are trying new things and gaming and running models, will provide a way for those communities to get closer together. And certainly industry would benefit from being able to work through some of this stuff, both in terms of responding to the aspirations, process aspirations of the clinicians, but also in terms of having a place to bring some wacky sort of technologies and apps along to, and saying, you know, if this were available, how might we integrate this into some care delivery environments? And then finally, for clinicians and clinical managers, we want it to be the resource and the environment for health service development. So it'll be the place where people come. And at the moment, we're very close to Heathrow Airport. I think that could be a tremendous benefit for us. Clearly, there are some problems to overcome, and so what we're doing at the moment is we're setting it up as a projects and events organization. So if people have real problems, we've got a community. We've signed up a number of universities. We've signed up a number of industrial partners. We have a community that can deliver, and particularly where we think we will be starting is projects that will take maybe between 1 and 3 months. Might cost between £15,000 and £50,000. So relatively well-defined projects to get people some exposure to what modeling can do with real problems. You know, we're building an extension when we want to reconfigure how people go through it. We're launching a new service. We've got a new clinic, or we're trying to troubleshoot a service which has had perennial problems. You know, that sort of problem we're set up to try and deal with right now. Eventually, we'd like to take on a significant problem, so across the nation. So, and this is a very rough guess, but for maybe up to about £5 million, we could probably have a crack at something that's proved very elusive by drawing people from maybe 6 different regions in and doing something. So we might do it with frail elderly. I think unscheduled care is an area where there's a huge amount of expertise, there's a huge requirement, and we haven't managed to bring that together in a successful way yet in the UK. Once we can do some big, something at a national level and show that we've got the evidence, we can begin to start walking individual care delivery organizations around that evidence-based improvement cycle. And when we can do that for maybe 10 to 15 service lines, I think we're close to having a mature offering where lots of people will want to come together. I just wanted to finish the spoken part and perhaps move into discussion by making a plea for our Festival of Evidence. One of the things that, as I said, we're short of in this area is an agreed idea across the communities of what constitutes evidence, and secondly, what evidence we're looking for, and thirdly, what is the evidence against those headings. We've planned a Festival of Evidence. There's a website address there for people to go to in October. And that's a list of the people who have agreed to come and give us some invited talks. So you'll see that the Mayo Clinic is there, got people from Australia. We've got quite a lot of North American representation, and we've got industrial and academic and clinical representation. So there's a real mix of people that are making a significant difference around the country and around the world there. And I've sort of taken a bit of a chance in trying to get this going. We're about 6 weeks away now, and we could certainly do with people coming and sharing what they've tried to do to get the evidence base, how they've tried to use systems thinking, how successful they've been, where they've gotten the evidence from, how they found evidence that persuades the different stakeholder communities. So if people are out there and are willing to share that, we certainly need that kind of stuff to come together. And if you want to hear some of the best people in the world who have worked in these sort of system-oriented parts of healthcare and are sort of starting to crack the problems, it's an opportunity to come along and hear them. We're running it on a ski pass basis, so you decide which days you want to come, and then you buy a ski pass for that number of days, and then you turn up on those days. And we're doing different topics from sort of hospital-based, clinical, community-based, looking at the interfaces, lots and lots. And there will be, there's at least one session where we're leaving it open for people to bring along problems and to do some interactive stuff on that afternoon. A real plea there for people both to sign up and come along, but also to put this in front of people who might also be willing to come along. It's a different sort of a way of doing things. I think we're on the verge of making a really significant difference. And all I don't know now, I feel like we're in a landing party that's going up the beach, and I don't know whether we're going to be the first wave that gets shot down or whether we're going to be the group that finally makes it and gets this kind of stuff working on a wider scale. Perhaps I can leave that up and hand back to you, Kat, to bring up some questions.
Fantastic, thank you. I hope you're the group establishing the beachhead and it's the Normandy landings all over again. Fantastic, what an interesting talk. I've barely been managing to tweet about it because I've been so involved in listening to what you've been saying. Can I ask a question? You've been so enthusiastic about modelling and it seems to provide so many benefits for healthcare if we can get the right people involved and build up the evidence base, and you said to get to the status of evidence-based medicine elsewhere. But what do you see are the major limitations for modelling in the healthcare environment, or of modelling rather? What can't it do?
At the moment, we don't really know how to model the softer bits. So there's a huge amount about patient experience and what it's the sort of the cultural aspects of a model. So at the moment, what you can say is, I believe that if I can make this work better, I can have more time to manage the exceptions or to manage the difficult elements around this. So it's not necessarily going to make patients happier on its own, but the belief would be that if you could guarantee what you could deliver to a patient each time, if the clinician that was looking after them was able to say, actually, every time I press this button or I ask for this service, it always comes within this amount of time, and you get that. The idea that if the service is more robust underneath, you should be able to offer a better service to patients and to keep them happier. That I think is one area. So managing the sort of the softer side, the cultural side, that piece is not really possible, at least not really well. There are one or two hero experiments and there are one or two modeling methods. Agent-based modeling allows you to work out if you give individual entities some beliefs and set them loose in a system to work out how they might go through the system. So there are some ways in which people are trying to capture these, but this isn't going to answer those kind of questions. And probably one of the big criticisms people would make is that, you know, patients are not nuts and bolts. Even if you smooth it all out, you haven't necessarily made them happy. And I would say that in isolation, modeling certainly won't do that for them. You've got to be using the modeler to help the overall system to improve and then work out, give yourself more time to solve some of the other problems.
Sure, but ensuring, you know, right care, right place, right time is definitely make people at least initially happier, and then you can address, as you said, some of the more complex, softer sides of patient experience. And I think when you mentioned the idea of a patient being able to model the system as well, I think that's a really helpful idea. The idea that you're not just going to be able to improve the conversation between different stakeholders from the delivery side about what we're doing and what works and what doesn't work, but from the patient understanding side. So we have more empowered patients who realize that actually if you give them an antibiotic for their cold, this is the knock-on effect on the whole system. I think that's a very interesting concept. From another sort of limitations viewpoint, I've come from a GP background. You've talked about A&E, you've talked about wide systems. Do you think modelling works on a small scale, like in an individual practice or ward?
I think one of the nice things about modeling is that you can stretch time back and forth, and you can also stretch the scale. I think a lot of a lot of issues around that GPs are facing will only be solved in this way. So already GPs are beginning to use systems for identifying the highest risk patients and to group those together. And if you could connect those models, and a lot of those patients will have multiple long-term conditions. So instead of the timescale being maybe up to 4 hours like it is in A&E, it's the same problem, but it's stretched out maybe over many months or many years even. So you've got the same sort of things going on. The patients are going from process to process, but it's not taking place in a few hours in one place. It's taking place over a much larger area between home and various clinics and stuff like that, and over a much longer period of time. But the basic decision making is very similar. And I think in many ways, the signaling is even more important. So to be able to signal ahead when somebody's long-term condition is reaching a stage where they're going to need to have a different sort of treatment, perhaps the diabetes is moving to a stage where they're going to have to start measuring their blood every day or whatever, or perhaps a degenerative disease is meaning that they're going to have to stop driving and they're going to have to move into a wheelchair or whatever. To be able to signal that ahead and to say, actually, of the 10,000 patients that we have in our catchment, we've got 5 that are going to be making this transition who have got this particular problem. That being able to signal ahead, I think, is really, really important indeed. And then to be able to signal back into primary care when patients are ready to be discharged and to have stuff ready ahead of time, all of that, I think, is really significant. So the scaling problem is almost invisible to modeling. And I think that we deal with A&E not because it's the most important, but because it's quite easy to conceptualize what's happening to people over a short period of time. You get to watch the whole you sit in A&E for 24 hours and you get to watch a whole set of complete stories almost. Obviously, in the primary care setting, the timescales are sort of stretched out over much longer periods of time, and you only see a small physically in one location, you only see a small piece of what's really happening. But the logistics pattern is underlying. The underlying problem is very similar.
Thank you. That really answers my question. I don't think we have any more. Oh, excuse me. We do have another question. So the question is, Terry, do you think that modelling is the precursor to automation, which is needed for more sustainable healthcare systems, is the question.
I think it depends what you mean by automation. I think one set of fears that people have around simulation modeling is that the robots are taking over, and there will be no humanity in the system at all. And I don't think that's what we're trying to go for at all. I think you want to automate processes that can be automated. So in clinical laboratory, most places enjoy really quite a good service. So there's a van that picks up samples. There's an electronic pathway that takes the data around those samples to the lab. The tests get done. The results come back in a pretty automated fashion. And you would like, on the whole, to find ways to make those kind of automated pieces work even better. So the information pathways, you would like those to be much better automated, so that information travels ahead of patients and is there when they reach that position, rather than finding that there are patients who turn up and you don't know anything about them, or you don't know anything about their history or whatever. So I think we want to automate certain types of process. I also think that protocol-based ways of delivering care, particularly in high volume, have a place as well. So there are a lot of examples, eyes, hips, those kinds of processes where you where in principle, having something that looks much more like a production line where you can get the costs down and particularly the defect levels down, which will reflect itself in much higher outcomes. I think that there's a place for looking at how those might be done. All this can do is make the mechanics work better. You've still got to wrap around that the real humanity of care. And I don't think you can automate the humanity of care. But the more reliable the underlying system is, the less frustrated, the more time people will have to put into that side of things. So I think that there's a balance there. Does that sound reasonable?
Yes, the questioner agrees with that answer. So everyone's in agreement that some kind of balance between the automation and the individual personal actions of the clinicians and others in the system needs to be struck, but hopefully that will be more sustainable for everyone. We're nearly coming to past, so I think I'm going to have to wrap it up there, and just remains for me to say thank you so much, Terry, for an absolutely fascinating talk. I know that it's given me a lot to think about, and I've scribbled down a lot of notes as you've been going. We will be sharing a recording of the session on the BMJ Quality website, so do have a look at that if you want to share it with anyone else who couldn't be with us live tonight. It's quality.bmj.com, and please do consider getting involved in the Festival of Evidence. We'll also put the link to that on the website so that people can see about either attending some of the really interesting speakers that they've got going, really worldwide experts, or, as Terry said, bring your own problems for modelling and share your examples of good practice. Anything you want to say as a final word, Terry?
No, I'm really happy to talk to people offline. That my email address is up there in the top right-hand corner, and I'm sure you'd be happy to pass on inquiries. Very happy to take the dialogue on after this. Thank you.
Wonderful. Thank you very much, and have a good evening.
Thank you.